Morning, everybody. Welcome here. Just give folks a sec just to come on in. Good morning. So sorry for starting just a tad late, just some technical difficulties as per usual on this Wednesday morning. My name is Sherry Lissy Sigerson, and I work at Shared Health, Mental Health, and Addictions as a prevention education consultant, and I will be your moderator for this first session for RAAM KE Days. Our host today is Jessica Johnson, and she will introduce our panel. As always, please put your questions into the question box, and they will be answered at the end of the session. We will curate the questions for our panelists today. And if you are looking for a copy of this presentation, it is located in the, it looks like a little it's in the materials portion with the little paper clip at the top of your screen. So I will hand this over to Jess to do introductions.
Good morning. Thank you, Sherry, and welcome everyone joining us today. So we have a really illuminating presentation for you this morning, looking at the intersection of needs for those who are at risk or are living with substance use and HIV. And this session is particularly timely as we have just passed the 37th annual commemoration of World AIDS Day, and we are in the middle of Indigenous AIDS Awareness Week here in Canada. So with that in mind, I'm going to very quickly introduce our presenters and then turn it over to them. So we have Dr. Fred Cota, who is a medical officer of health in Western Manitoba, Dr. Ireland, who is a medical director and primary care lead with the Manitoba HIV program and 9 Circles. And we're welcoming back Dr. Sarah L'Esperance, who is a medical officer of health here in Winnipeg. So that will be very quick, and with that, I will turn it over to yourselves.
Good morning. You can hear myself? Okay, perfect. I'm Dr. Amy Fakota, and I will not introduce further beyond this at this point, so we'll move to the next slide. I would like to begin with a land acknowledgement, and for myself, it is important to acknowledge the land because growing up in Canada as a settler, I never heard land acknowledgements. Contemporary and historical Indigenous presence and land rights were not recognized, and gratitude to be able to live on these lands and to those who stewarded the lands really was not acknowledged. Indigenous people were often talked about in harmful and racist ways, and treaties were thought of as past events. They were not acknowledged or appreciated for present relevance. The impacts of colonialism were also not acknowledged. Due to the nature of what we're presenting today, colonialism has a substantial impact on the data and what we are presenting today. So I do want to acknowledge that I live and work on the original lands of First Nations, Inuit, and the homeland of the Métis Nation. And this is also an acknowledgement on behalf of my co-presenters, Dr. Ireland and Dr. L'Esperance. I acknowledge that the term Indigenous does not do justice or encompass the diversity of people to whom it's used to describe. I acknowledge the systems of oppression that have dispossessed Indigenous people of their lands and denied their rights. And I commit to amplifying the voices of Indigenous peoples and working against the everyday forces of colonialism present. As I said prior, in regards to this topic of presentation, HIV and substance use, I acknowledge that the data I'm sharing and the impacts on Indigenous people of this disease and the chaotic use of substances is a direct result of colonialism and systems of oppression. And I, along with my colleagues, would like to be part of change and healing in responding to this. Next slide, please. The objectives of what we'll be sharing today. I will be providing an overview of the current HIV data in Canada and Manitoba, and I'll also be speaking to substance use. Dr. Laurie Ireland will be speaking in regards to HIV testing, prevention, and care. And Dr. Sarah L'Esperance will be speaking in regards to harm reduction. Next slide, please. And we'll go to the next slide, I think, as well. Perfect. Across Canada, there has been a rise in many sexually transmitted and bloodborne infections. When we talk about sexually transmitted and bloodborne infections, we are referring to infections of HIV, hepatitis, syphilis, chlamydia, and gonorrhea. We tend to pay special attention to HIV because although this virus, as we know, can be managed with appropriate daily medications, it is a lifelong disease. And if it is not well managed, it can be more easily shared between people. The map that you're seeing here is from federal national figures that were released just on December 1st, so 2 days ago. And from this map, which is quite tiny to see, but if you're able to zoom in, you can see that Manitoba has the highest rate of new HIV diagnoses. This figure shows new HIV diagnosis rates per 100,000 population in 2024. It was just released 2 days ago, but it's the data encompassing the year 2024. If I go back and share the data from 2022, the rate of HIV in Manitoba for new cases was 13.9, and at that time Saskatchewan was 19. We are the two highest provinces in Canada for new HIV diagnoses. In 2023, Manitoba increased. It was still below Saskatchewan, and now in 2024, Manitoba has the highest rate in Canada and has surpassed Saskatchewan as well. And this rate is over 3 times higher than the national rate, which is 6.1, or there may be a slightly lower number as well. We're waiting for some further data from Quebec. Manitoba HIV program has named this issue a syndemic. A syndemic is when we have health conditions that overlap. And these health conditions that are overlapping, they worsen the negative effects of the overlapping conditions. What we are seeing with the syndemic is a congruence or overlap of issues of homelessness, poverty, substance use, trauma, mental health, and despair, and outbreaks of infections such as HIV. We are seeing this syndemic, this overlapping, occurring in many of our communities. We can go to the next slide. This slide is a number of different and recent topics that were in the news. I just snipped these topics and put them together on a slide. And they show what I'm sharing about a syndemic. So if we look at some of the topics, Manitoba has the highest rate of stimulant toxicity deaths in Canada. More action is needed to face the meth tsunami. The future of kids at stake as poverty rates in Manitoba ridings amongst the highest in Canada. AMC, which is the Assembly of Manitoba Chiefs, responds to record homelessness in Winnipeg. And then we have, breaking it down even further at the bottom right, 5 years ago, city ERs saw less than 1 meth user a day. Now on average, 8 patients a day arrive at hospitals under the influence of meth. And not just any patients, it says in the article. So these are all examples where we're seeing the congruence or overlap of this syndemic, of these issues of homelessness, poverty, substance use, trauma, mental despair, and outbreaks. Next slide, please. This slide is showing the number of people diagnosed and referred to the Manitoba HIV program over a short period of time here. Pardon me, the number on the bottom is saying just how many were referred in 1 year, but the slide is showing all the way back from 2014 up to 2024. And as you can see, HIV is increasing in Manitoba, which we've shared from the other national data already. And what I also wanted to add with this is that the cases of HIV, they're very complex cases. They're presenting with very low immunity. Sometimes they're already presenting with end-stage illness, AIDS-defining illness, when they are presenting and they have not had the chance to receive care prior. Increasing number of clients are not connecting or remaining in care or adhering to medical regimes. And there are a number of clients as well that are struggling with methamphetamine use amidst this. Next slide, please. As we know, HIV spreads through activities such as unprotected sex or sharing needles during injection substance use. Unlike the national trend, and in the national trend, we see that sexual contact is the primary transition route. In Manitoba, both injection drug use and sex are the most common modes of acquiring HIV in Manitoba. Next slide. This is a slide showing the red is Indigenous clients and the yellowish orange are non-Indigenous clients. And as we can see, Indigenous peoples have been overrepresented with HIV since 2016. Indigenous people in Manitoba are most affected by HIV and this endemic due to the ongoing impacts of colonialism, racism, and due to the trauma that has spanned many generations. Next slide. This slide is showing that we are seeing a growing proportion of females that have been impacted with HIV since 2018. The blue is female and the yellow are males on this graph. And there have been an increase in the number of female cases. These women are typically young, 20 to 29, and are disproportionately self-identified as First Nations, Métis, or Inuit. And with that, also I did want to just share, it's not on the slide, but in Manitoba, we have had confirmed cases of infants that have acquired HIV from vertical transmission, from mother to infant. We had one confirmed case in 2024 and one confirmed case thus far in 2025. Next slide. Females also are disproportionately impacted by this endemic. If we look at the analysis of people referred to the Manitoba HIV program, females living with HIV were also more likely to experience houselessness, and mental health conditions. As you can see, females are the blue and males are the orange on this graph. Females are more likely to use injected drugs and methamphetamine, and they are also more likely to be diagnosed with an STBBI prior to their HIV diagnosis. And again, we are seeing this endemic, this overlap of health issues, young females associated with methamphetamine, poverty, unstable housing, and substance use, as we shared with the methamphetamine. Okay, next slide. This next slide shows information from the most recent full Manitoba HIV program report. And from this report, among all new HIV cases in Manitoba, 50% of the new HIV cases that are females are houseless, and 25% of the males are houseless. The females, 65% of the new cases reported substance use through injection, and 70% of those that injected substances used methamphetamines or crystal meth. Okay, next slide. As I'm sure many of you are aware, crystal meth is a long-acting stimulant, and it can help with concentration, energy, wakefulness, and self-confidence. So there can be benefits, we'll say, with crystal meth use. It's very cheap and it's extremely easy to access. People may use crystal meth to help cope with traumatizing experiences. They may use crystal meth to keep themselves safe, such as a person who is houseless or in a vulnerable situation. They may use crystal meth to keep themselves awake in order to protect themselves from danger. Meth is easy to inject because it dissolves in water, and we do know that the term shakers can be used with meth, and that's a drug practice preparation in which the barrel of the syringe is removed, the drug in its powder form is dropped into the syringe, and it's just dissolved by shaking. This practice doesn't require heating of the drug, and heating of the drug can assist with killing bacteria, microorganisms, and as well, because you're not heating it, you may still have some small particles that remain in the liquid in the syringe, and those can harm the walls of veins, venous walls, and can cause buildup in the small arteries of the lungs and lead to also problems with infective endocarditis, infection of the heart. So if we go to, before we go to the next slide, just at the last part of this is the statement that polysubstance, 47% of people who died of fentanyl overdose had crystal meth in their system. And this was from a study that came out before the pandemic in Manitoba, a review of death cases related to substance use. And this was noted in Manitoba, the high proportion that we're seeing of crystal meth along with people who are dying related to opioid overdose. Okay, next slide. Some of the harms as we're seeing from crystal meth, as people are using this to stay alert, they can have little to no sleep for several days. Sleep deprivation of this magnitude obviously can lead to mental health and behavior challenges. Due to the stimulant effect, people may act disorganized, disruptive, chaotic, and people can act violent. It can cause psychosis. And as I said, meth is easy to inject because of the ability to dissolve it in water, and that has associated risks to, one, lead to further infections, such as infections in the heart, infections in different other parts of the body where we'll have abscesses and so forth. And we can also have bloodborne infections that are shared as well through the sharing of needles, such as HIV. And I'll pass it over to Dr. Ireland. Thank you.
Thanks, Dr. Fukuda. I'm going to talk a little bit about HIV and focus today on prevention, including PrEP and PEP and treatment as prevention. So next slide. I'm going to start just with a reminder of what HIV is. It's a retrovirus. It needs a host, doesn't survive outside the body. It's spread through blood, genital, or rectal fluids, and more rarely through breast milk. Primarily, it's transmitted, as Dr. Fukuda said, through unprotected sex and sharing needles or drug use equipment with someone who's living with HIV. If someone's to become infected, it infects their CD4 cells. Those are the cells that direct and coordinate our immune system. In HIV without treatment, those CD4 cell counts decrease over time and the body loses its ability to fight infections. Without treatment, people become at risk of what we call opportunistic infections, are more at risk of some cancers and ultimately death. Next slide. Thankfully, treatment has progressed over the years. From the first available treatments that help people stay alive in '87 to highly effective combination therapy in '96. Today, we see most people are treated with a single pill, one tablet once a day, generally well tolerated. Probably the most common pill or medication people are familiar with is Biktarvy, where there's new injectable options that are taken every 1 to 2 months. Treatments recommended for everyone living with HIV, and best outcomes come with early treatment as soon as possible after diagnosis. And really, life expectancy around the world for someone living with HIV is nearing that of the general population. Unfortunately, we see poor outcomes, as Dr. Fukuda mentioned, from endemic conditions or other comorbidities. And when someone's on treatment, their viral load goes down to undetectable levels, usually within 1 to 3 months. That makes HIV untransmittable, or undetectable equals untransmittable. Untransmittable is a U equals U concept, means it can't be transmitted through sex. And treatment is now free for all Manitobans through the Manitoba HIV treatment program. Next slide. Unfortunately, people are still facing barriers. Even though we have free access to medication, simplified treatment available, we were able to look at our cascade of care in Manitoba. The UNAIDS sets goals for the cascade of care at 95% of people being aware of their diagnosis, 95% on treatment, 95% with a suppressed viral load. And you can see we are not meeting those targets. In Manitoba, approximately 2,500 people have been referred for care, while we're seeing about 90% have been able to link. Only about 3/4 or 75% are on treatment, and 68% with a suppressed viral load. So facing some missed opportunities to help support people on treatment and also prevent onward transmission. Next slide. The first thing we can do to address the epidemic of HIV is to test. So these are the Manitoba Health testing recommendations. There's also specific HIV testing recommendations available on the HIV program website. And really that align, everyone should be offered routine testing as part of their medical care. And anyone at higher risk should be tested more frequently. Anyone with new or multiple partners, if you or your partner inject drugs or share drug use equipment every 3 to 6 months. In pregnancy, we shouldn't see infants born with HIV. We can prevent vertical transmission if we're aware of an HIV diagnosis and someone's on treatment, so testing 3 times in pregnancy, and then anyone who has symptoms or requested HIV or STI testing. And when testing for one, test for all sexually transmitted infections, so that's or bloodborne infections, so that's hepatitis, gonorrhea, chlamydia, syphilis testing along with your HIV testing. And I've just included some links to our testing recommendations. And then on the Street Connections website, there's a location of services where you can see where people can go for testing. Next slide. When results come in, this should trigger a discussion whether results are positive or negative. This is called an HIV neutral approach. It was developed in the New York Health Department, but endorsed by the CDC in the States in 2021, and really encourages a neutral approach, stigma-free approach to responding to someone's HIV results, to address other endemic conditions that may be affecting someone's risk for HIV, offering triggers, offer of preventative services and offer of supportive services to address some of those risks or other conditions. And then also, if test results are positive, to refer for care and treatment and to reassure. Next slide. So if someone tests negative for HIV, this does provide an opportunity to talk about prevention, and one of the excellent preventative options for people that may be at risk for HIV is pre-exposure prophylaxis, or PrEP. PrEP is for the prevention of HIV in an HIV negative individual. Someone must have a negative result within 2 weeks before starting PrEP, and then monitoring is done a month following, every 3 months, with STBBI testing and renal monitoring. And the main drug used for PrEP is tenofovir disoproxil fumarate and emtricitabine. That's Truvada, 1 tablet once daily. It is covered by NIHB, by EIA, our Manitoba HIV treatment program for all Manitobans. Very well tolerated. Extended use could potentially have negative effects on kidney or bone health, and that's why we do the renal monitoring. And you can see there the data is excellent for the prevention of HIV. The PROUD trial was in gay or bisexual men who have sex with men, up to 100% reduction, 96 reduction seen in the Partners PrEP trial for heterosexual population, and up to 74% reduction in people who inject drugs in the Bangkok PrEP study. And all of the data with reduction is linked to adherence. So for any population that anyone who wants to start PrEP, really it's all tied to adherence. If you're able to take a pill once a day, it is highly effective to prevent HIV. Next slide. So there were new PrEP and PEP guidelines just published 2 days ago on December 1st. They're in the CMAJ, and I've included a link to the new guidelines. We also have guidelines on the Manitoba HIV program website. Primarily, PrEP has been used for gay or bisexual men who have sex with men, inclusive of transgender individuals, heterosexual with partners that have HIV that might be transmittable, meaning that they have a detectable viral load, or for people who inject drugs. With the new guidelines, it's really promoting expanding eligibility for PrEP. Next slide. So it really highlighting that PrEP is a safe and effective intervention and should really be offered to anyone who requests it. And the guidelines really are promoting expanding and offering to anyone who requests it. Next slide. There are also some validated tools that can be used. The HIRI is a high index risk indicator for men who have sex with men. The ARCH IDU for people who inject drugs. That it's a series of questions that then give a risk score to with cutoffs that suggest, and if the risk is higher, that people should be offered PrEP. And again, those are available in the new guidelines. Next slide. There are other PrEP regimens available. I'll just speak quickly on these. On-demand PrEP can be used, but is not recommended for cisgender women if they have hepatitis B, or for people who inject drugs where the risk might be blood-blood transmission, mostly based on the fact that levels might not be high enough in the vagina or to prevent blood-blood transmission, or there's risk for hepatitis B flares with on-demand dosing. In that known as 2-1-1, you take 2 pills 2 to 24 hours before sex, and then a pill every day for 2 days. Tenofovir, alafenamide, plus emtricitabine or Descovy is a more renal safe option for PrEP, but is not covered by Manitoba Health. Next slide. There are some pending PrEP regimens. Cabotegravir, it has an indication for PrEP. It's a long-acting injectable that's every month for 2 months, and then every 2 month injection. It's not yet on the Manitoba formulary, but may be coming to the Manitoba formulary. There are some concerns. It's pretty strict on the timing of the dose. So if people are late for an injection, the levels decrease in the body. And if someone's at ongoing risk for HIV, it's recommended that oral medications are added back. Pending a Health Canada review, lenacapavir is a subcutaneous injection capsid inhibitor that hopefully will be approved and is looks like the potential to be highly successful in HIV prevention. It's an every 6 month subcutaneous injection, and the data shows really quite amazing results to prevent HIV. And there's 3 studies pending results to evaluate its use in people who inject drugs. And next slide. I'm going to switch gears a little bit to talk about PEP. PEP is also for someone who is HIV negative. To prevent HIV after an exposure, it needs to be started within 72 hours of a potential exposure. It's 3 antiretroviral medications that are taken for 4 weeks. Because of that timeline, within 72 hours, it's an urgent assessment to decide if someone may be eligible for PEP, and that's why it's done in the emergency department or urgent care. So the assessments are done to assess what was the type of exposure. Was it moderate or high risk, such as vaginal or anal sex, or a percutaneous blood exposure? And then was this source, did the source have a substantial risk of having transmittable HIV? So that's someone living with HIV with a known viral load that's over 200, or someone with an unknown HIV status that's from a prevalent population that's may be at risk for having HIV. Then PEP would be offered. Next slide. The timing is really important, and that's why there's that 72-hour cutoff. The data from that comes from animal models and pharmacokinetic modeling. That there, within the animal models, no transmission was seen if it was initiated within 24 hours. There's partial protection up to 72 hours and no benefit beyond 72. So that effectiveness really starts to decline quite rapidly after 48 hours, but still may have some benefit up to 72 and not beyond. Next slide. The evidence for PEP is also excellent. Well, I think I flipped my slides. So the starter kits that come in the emergency department are for tenofovir and emtricitabine or Truvada plus raltegravir. The raltegravir is a twice daily dose. If someone has decreased renal function or kidney function, the starter kits are a renal kit, which is Comivir, which is idovadine and lamivudine twice a day, plus raltegravir twice a day. So kits are given for 3 days, and then a prescription is written for the remainder of the 28-day course. And again, it's fully covered by NIHB, EIA, the HIV medication program, or alternatively might be workers' compensation or victim services. The new guidelines highlight preferred regimens that are once daily, either Biktarvy once daily or Truvada and dolutegravir once daily. Unfortunately, they're not covered by Manitoba Health. They are open benefit from NIHB. So if some people are being seen for PEP and there's concerns that they may have difficulty adhering to that twice daily regimen, that would be a consultation with the HIV program pharmacist just to confirm coverage. And it's not recommended to delay treatment. So those starter kits are really important, and their details of PEP is available in our provincial protocol. So starting that starter kit right away is really important to prevent HIV. Next slide. The evidence for PrEP also is good. There's no randomized control studies because we ethically couldn't do that to not offer PEP if someone's potentially been exposed, but the data from systematic reviews is excellent, following up on over 30,000 excuse me, PEP dispensations across several studies. And over 10,000 had follow-up testing. There were only 7 seroconversions and 4 had ongoing high-risk exposures prior to the follow-up testing, and another 2 had some non-adherence to the medication, so highly effective to prevent HIV if someone's had an exposure. Next slide. Follow-up testing for PEP is then done 4 to 6 weeks after an exposure, at 12 weeks, and then again at 6 months. If there was a conversion to someone acquired hepatitis C, it can interfere with antibody formation. So it's recommended that 6-month follow-up if someone acquired hep C after the exposure. For follow-up in Winnipeg, there are a number of sites in the community that will follow up for that testing. 9 Circles, Access Fort Garry, Access Winnipeg West, McGregor Clinic in Norwest. There also is an option for people. It's outlined, the details are in the new Canadian PrEP guidelines, but if someone's at high risk, has had repeated PEP courses or wants to transition to PrEP, that can be done. And how to do that's outlined in the guidelines, but when they come back for that 4-week testing, can convert that 3-drug regimen to 2 drugs for PrEP if they're at risk and want to continue on PrEP. Next slide. This is just a snapshot from the new guidelines. This is an excellent, just 1-page summary. In the link there, the risk assessment tools are in the guidelines. Details of recommended regimens, tables for baseline assessments and monitoring labs. If people want to go check them out. Next slide. Just in my few remaining slides, I'm going to focus on if someone's newly diagnosed with HIV. Ideally, someone is informed of their diagnosis as soon as possible after a positive test. It's important to reassure, let people know that there's good treatment available. Being on treatment can prevent transmission to partners. Being on treatment prevents vertical transmission, can have healthy sexual relationships and have infants without HIV. So it's really important to sort of share some of that knowledge when someone's first infected. We have a handout or information sheet on the Manitoba HIV program website that can be used to guide that conversation. When people know they have HIV, they protect their partners, having that discussion to review any ongoing risks, linking people to supplies. The Street Connections website has a map of services that can be used. The STBBI form should be filled for contact tracing, and the link to that form is included in the slide here. And then people should be referred to the HIV program for care and treatment. And the link to our referral form is there. It's also in Acuro and on our website. Next slide. The HIV program has been working to expand HIV care around the province into primary care. with that over 300% increase in people diagnosed. It's no longer sustainable to have a centralized care service that was primarily in Winnipeg and Brandon. There's also lots of great evidence that people do well for HIV care within primary care, and primary care providers are well suited to provide the enhanced screening, immunizations, chronic disease management, and management of comorbid conditions. And we see increased linkage to care, increased uptake of treatment, excellent preventative screening, chronic disease management, and also it goes a long way to reduce the stigma of living with HIV, to be sort of normalizing care within the primary care setting. So we have been able to expand some of our HIV program care sites. Next slide. Our specialty care site has a multidisciplinary team at Health Sciences Center who provide care in the city and around the province in collaboration with primary care providers. We now have 5 primary care sites, 3 in Winnipeg, 9 Circles, Aboriginal Health and Wellness, and Access Downtown. We have partners up in Thompson providing HIV care, and have been developing emerging partnerships with clinics in Northern Prairie Mountain Health, as well as partnering with Oncommazin to develop an Indigenous-led framework for care in our northern and remote communities. We also have 3 outreach teams known as PATHs. That's the Program to Access Treatment for HIV and Other Supports at Aboriginal Health and Wellness, 9 Circles, and in Brandon. And those teams are providing care out in the community to help address some of the barriers that many are facing and having difficulty accessing care in more traditional settings. So when seen, next slide, when seen by the program, we will facilitate a baseline assessment, rule out opportunistic infections, start prophylaxis needed and start treatment, and then collaborate with primary care for ongoing treatment and monitoring. Next slide. We also have primary care recommendations available on our website that are meant to support primary care providers around the province to collaborate for HIV care. It has details on immunizations, other screening, and our lab monitoring schedule. Next slide. The HIV program is also available on Tiger, so if anyone needs an urgent consultation, if you search under the teams on Tiger for HIV, a team will come up that can be sent a message as a group that includes our pharmacists, primary care providers, and our specialists. Non-urgent consults can go through eConsult. We also have a client engagement coordinator who's available over the phone for service navigation. Next slide. And as mentioned before, being on treatment prevents transmission. We see with growing data, the data that was first established for treatment as prevention was back in 2011, and a more recent systematic review shows evidence that there's near zero risk for sexual transmission when a viral load is less than 1,000. We also know that HIV treatment prevents vertical transmission, and a systematic review saw if we see that viral loads are less than 50, there's zero transmissions from to infants. Next slide. Just conscious of the time. So my last slides were just around opiate agonist therapy. Great evidence to show that offering addiction support with opiate agonist therapy can reduce risk behaviors, reduce HIV transmission, either alone or in combination with other prevention tools, increasing testing rates and supports linkage to care and treatment. Next slide. Unfortunately, people who inject drugs aren't as likely to receive HIV treatment, but OAT, either methadone or buprenorphine, increases that offer for care and treatment, and we see people do better with improved adherence and increased viral suppression. Next slide. We also see that PrEP is underutilized in people who inject drugs. As mentioned before, the data for the effectiveness of prevention is excellent, and there's growing evidence from the studies shown here that supporting PrEP with OAT can be highly effective to prevent HIV. Next slide. And this was just a summary that integrated HIV testing, prevention, linking to care with supported services like OAT can improve our local HIV cascade of care in Manitoba. And I'm just going to pass over to Dr. L'Esperance.
Sure, thank you so much. So I'm Dr. L'Esperance. I'm going to move into a bit of a conversation around HIV harm reduction. Next slide, please. So this is just a reminder that harm reduction is an approach to substance use, and we can apply this to substances like alcohol, cannabis, methamphetamines, or any other substances. And we can think about it in terms of drug policy as well. The real goal with harm reduction is to reduce the negative impacts that may be related to any type of substance use. It can also be applied to other stigmatized practices like sex or sexual activity, but it could also be applied to non-stigmatized things like driving a car or riding a bike. We think about seatbelts and helmets, for example. Again, the real goal of a harm reduction approach or work in the harm reduction sphere is to support health and well-being and to connect with people in whether it be individuals or communities, and really to focus on doing that in a non-stigmatizing way. We often hear the idea that harm reduction is an approach to working with people where they're at, and that really means that we approach a conversation around harm reduction with a respect for a person's unique circumstances and experiences which may have brought them into contact or relationship with substances. When it comes to things like HIV, the harms that we're particularly concerned about are the harms related to substance use like injection drug use or unprotected sexual contact. That's okay. Next slide is great. Thanks. So just as we think about harm reduction, and sometimes we think about it as a practice like sterile needle distribution, it's important to recognize that it's only one part of a response to substances, and it does fit within what we often call the 4 pillars, which is supported by Health Canada's drugs and substances strategy. So harm reduction is really the idea of using people, means helping people during their greatest struggles, and also connecting with people during their substance use, not necessarily after, while recognizing that the road to health can be a long and challenging one, and that everybody is deserving of support. So just as there is a continuum of substance use itself, there's also a range of responses to substances. So enforcement really involves all of the rules and regulations that we make about substance use, such as whether a substance is legal or illegal, and the laws that we have about substances and how they may be used in society. Prevention is really the goal of minimizing the harms of a substance before that harm occurs. So we're trying to interrupt the cycle before there is a health issue of concern. And harm reduction is really that idea of the goals of preventing harms from occurring related to the use of substances, without necessarily emphasizing that that substance use has to stop in the moment. So it's a little bit different from an abstinence approach to responding to someone with substances. And then, of course, treatment involves any of those sort of responses to higher risk substance use, or where substance use is really making a lot of issues in someone's life or causing a lot of complications. And so this is when it does become problematic, and so we'll often see treatment through medical intervention and or mental health supports. The whole idea around this continuum of harm reduction is recognizing that the stigma that is related to a lot of the issues that we engage with individuals on. So when we think about things like sexual infections, just having chlamydia or gonorrhea, there's a lot of stigma often associated with that. There's a lot of stigma in society related to substance use, particularly if it becomes problematic or if it includes things like injecting that substance. And then also HIV status just as it is. Dr. Allen referred to the HIV neutral approach, and really that's the idea that harm reduction approaches operate in a non-stigmatizing environment, where much like, in this picture here, asking a driver to hand over their keys, we're not making a judgment of the driver that they're consuming alcohol at an event. We're basically just saying, like, let's find a way to make sure that we keep you safe. It's the same thing with harm reduction related to substances, including things like injection drug use. We're not having a moral debate in the moment around whether or not this is a good thing. We're talking to you about what is it like, what is the impact for you of say, if you are injecting substances, and what are the harms that you're occurring, and how can we work together to kind of minimize those harms. Next slide, please. So the history of harm reduction really has been born out of the 1980s. We saw a lot of epidemics in Europe in the 80s, particularly HIV and hepatitis B and C. Injection drug use was particularly associated with these events and seen as being a major route of transmission. It also was associated with an awful lot of stigma and not a lot of recognition by mainstream medical systems. And so you saw a lot of grassroots activism occurring within the community as people began to emphasize and demand that they be seen and treated and cared for by the medical community and provided assistance with reducing the harms of their substance use. And so you did see by the late 1980s and the 1990s that countries like Netherlands, Switzerland, and Germany began to integrate harm reduction strategies into their broader public health frameworks. And now we've seen harm reduction as a key component of Canada's drug and substances strategy. Next slide, please. Part of the reason why we see this integration of harm reduction in practice in response to substance use kind of broadly is that there's a lot of evidence to support the positive outcomes and the harms that are in fact reduced from harm reduction practices. And so we see this broad adoption of harm reduction programs, whether within Europe, in North America, or even endorsed by the World Health Organization. So the reason this endorsement occurs is that harm reduction programs have actually been shown to reduce the number of harms that we have that we're concerned about in public health, particularly as we're talking about today. HIV risk reduction is known given the way that HIV can be transmitted, particularly through sexual contact or through sharing of injection drug use equipment. We also know that it can reduce high-risk behaviors among people who inject drugs. So, having a conversation with someone about how to reduce the health harms of injection drug use, for example, infections on the skin or locations in the body where injection may occur, harm reduction practices and engaged conversations can help to reduce some of the harmful injecting practices. Conversations around how to discard needles safely are also part and parcel of any harm reduction intervention, as we'll see when I talk a little bit more about supplies next. And also making sure that people have connections. So harm reduction isn't necessarily just, a conversation around substance use. It's also talking about what are the things that we want to move to next. So when we talk about HIV harm reduction sort of broadly, the whole idea of knowing where you're at and knowing what your status of HIV is at the present moment. Sorry, Jessica, are you giving me a notification for time? Sorry?
Yes, but you can finish those last few slides.
Okay. Sorry, everyone. Apologies for rushing. So what you can see here with HIV harm reduction is really the things that we can do in advance. And a lot of these things I'm not going to go over under Know Your Status because Dr. Ireland has covered them in good detail. So, but I'll talk a little bit more around some of the HIV transmission risk reduction and what we talk and think about when we look at harm reduction supplies. Before I go, just 1 second to the next slide, I'll just mention substance landscape conversations are also often a part of our harm reduction interventions. Recognizing, as Dr. Fukuda has emphasized, the amount of methamphetamine and the linkages we have seen in the province related to injection drug use, particularly methamphetamines, really is an important sort of conversation to be aware of when you are having harm reduction conversations with individuals who use substances. the result is that sometimes we think about methamphetamines as a stimulant. They can potentially enhance someone's interest in sexual activities or even take away a sense of risk of concern. For example, not really feeling almost invincible and not really feeling like you're at particular risk for HIV transmission in the moment. So often having conversations around the substance landscape and the particular harms that we know are associated with some of the substances if someone happens to be using meth is an important part of a harm reduction conversation. I'll turn to the next slide now and just give you an overview of what we think of as some of the classic harm reduction supplies. So here we see a couple of things that we will use or distribute to individuals, often as a harm reduction intervention. You can see on the left at the top a number of supplies that are distributed to improve the safety of injection practices. Things like a tourniquet, things like alcohol swabs. In the blue bottles there, the stack of 4 there, that's sterile water. And of course, we see the needles that are provided, sterile needles. And then up here at the top, what you see in the middle, again, I appreciate it's hard to see, is a cooker. And so this is just a device that someone can use to cook or to heat their substance to assist with liquefying it. And also it has a bit of a filter so that it can be used when drawing up substances in the little cooker. Just try to interrupt some of that particulate matter that can put people at greater risk for endocarditis. We also see conversations around where is a safer injection site. At the bottom, you can see bubbles and stems, and these could be used if someone is smoking a substance as opposed to injecting it. Although in reality, we often see individuals engage in a combination of the two. And then you can see the sharps container, which is distributed with all of the handouts of harm reduction supplies, so that everyone has access to that. And then on the other side, you can see some of the like condoms, lube, female condoms that we tend to distribute as a harm reduction supply. And then there's options when available for HIV point of care tests, handing out naloxone through the take-home naloxone kit program is really a key component of harm reduction as well, because of the particular risk of fentanyl or other opioids in the illicit supply. And then other things that, again, Dr. Ireland has referred to when we talk about PrEP or PEP or having ongoing treatment as reducing your risk of transmission, and then real positive effects we see of reduced transmission risk when people are on OAT. Next slide, please. Next slide, please. So just briefly, HIV is here as a bit of an approach that we had worked at Street Connections along with 9 Circles to develop in collaboration with the community. A number of community consultation circles were held and questions were asked around what do you know about HIV, sort of what's the word out there, and we had found some interesting response from community, a lot of descriptions of there being a need to have greater conversations around HIV, some misperceptions about HIV, the risk of it as not being something that may be a concern for people who engage in heterosexual contact. And so just kind of dispelling some of the myths, people feeling that HIV is a death sentence, that it's not worth it to necessarily go and seek care or support. And so really understanding and getting a better appreciation for the perceptions in the community related to HIV led to the development of a number of prevention strategies and interventions, and just also a response from the community to let's get the word out there. People don't know. Let's put out posters. Let's make sure that people in our community are aware and are thinking about HIV. So as a result of this campaign, which was designed by and with community, the idea around HIV is here. Is in the conversation on HIV is associated with all distribution of harm reduction supplies. Next slide, please. And this is my last slide. So just to emphasize, that really the idea that harm reduction can be a bridge between prevention and treatment, and it doesn't end in the conversations that we have with people around how to reduce the harms of their substance use and reduce their risk of HIV. It really does blend quite seamlessly, ideally, into supports into getting people connected to some of the resources that you see here. And with that, I will stop. Thank you very much.
Thank you so much, doctors, today. The words both sombering and hopeful are going through my mind as you shared your presentation, that we have, real needs and things to address here in Manitoba, but that there are also so many tools and resources and care that can be provided. So on that note, I will thank you for your presentation. Thank you everyone in our audience today. And we are going to wrap up and end our session. Have a great morning, everyone.